thanks for the organized committee for inviting me to join this wonderful conference. Initially, the topic that I was given is obesity and polycystic ovary syndrome. So I'll stick with this main theme, although I'll briefly touch upon the metabolic issues in obesity. Yep. So I'm a gynecologist with a special interest in reproductive endocrinology. So I think I'm a rare kind of person to be present in this the conference, which I suppose all of you or most of you are metabolic physicians and surgeons. Yeah. But at the end of the talk, I hope I will convince you that obesity is actually a topic which is quite relevant to our field, especially in reproductive endocrinology. Yep. And polycystic ovary syndrome, now all of you who work in endocrinology, I think know this the condition well. This is actually the commonest reproductive endocrine disorder and is the commonest cause of anovulation among women in the reproductive age. And the prevalence is around 10% as reported in meta-analysis, although the actual prevalence do vary quite a bit between different populations. Now, this condition was initially reported by Stein and Liebenthal in the 1930s, long time ago, who first discovered some kind of association between anovulation and also the appearance of multiple cystic structures in the ovary. And subsequently, of course, they identified that androgen excess seems to be one of the hallmark features of this syndrome as well. Yep. And throughout all the decades, actually, there are various clinical, biochemical, and sonographical parameters that have been used to define this condition. And I think there has been no consensus for quite a number of years until the recent decade, when there was an international consensus that has been put up to define this condition. Well, what I'm referring to is the consensus meeting in 2004 in Rotterdam. So in that meeting, all the experts in this field have come to the agreement that PCOS is the best to be defined based on 3 criteria: oligoanovulation, clinical or biochemical hyperandrogenism, and the presence of polycystic ovary morphology on ultrasound scan. Yep. So the presence of either 2 out of the 3 will constitute the diagnosis of polycystic ovary syndrome, with the exclusion of other etiology. You know, sometimes there can be some other endocrinopathy which may cause anovulation and may have similar presentation. Say, for example, congenital adrenal hyperplasia, other causes of androgen excess. So we have to exclude all those before we label the woman as having polycystic ovary syndrome. Okay, and the international experts have just met last year again, try to reach such a consensus document. This is called the International Evidence-Based Guidelines for the Assessment and Management of Polycystic Ovary Syndrome 2018. So this statement, this guideline was put up jointly by quite a number of international organizations specializing in endocrinology, gynecology, as well as reproductive medicine. Yep. So basically, the guideline adopts the Rotterdam criteria for the diagnosis of PCOS, except they make some modification on the definition of polycystic ovary feature. Now, previously at the Rotterdam consensus workshop, they adopted a paper in more than a decade ago, saying that if the antral follicle count is more than 12 in an ovary, this is defined as polycystic ovary. But with the advent of the ultrasound technology, we are now seeing more and more of those as small follicles, even follicles like 1 or 2 millimeter. We can now see it with confidence on ultrasound scan. So people seems to be seeing more and more follicles, which if you stick with 12, then probably quite a number of the women will be labeled as having PCO. So they refine the diagnosis criteria as an ovary with 20 or more follicles measuring 2 to 9 millimeter in diameter, right? Or if the ovarian volume is more than 10 cc, then this is the being called polycystic ovary feature. So this is the new criteria adopted in this international consensus guideline. And only one ovary fitting this definition is sufficient for defining PCO. And if there's a dominant follicle more than 10 millimeter, that means this may be around the time of ovulation. Then the follicle counting may not be accurate, and you have to repeat the scan in the next cycle, preferably in the early follicular phase. So this is currently the definition for polycystic ovary syndrome.